hear me okay?
Yeah, I can hear you well, George. Hi.
Great, Kevin. It's been a little while.
It has. How are you doing?
Can't complain. Not too bad, thank you. How are you?
I'm good, thank you. Did we pull you out of the OR today?
It's a stereotactic biopsy.
Okay.
I was a little worried there'd be a conflict, but we're good. We're in good shape.
Perfect. I'm glad you could join us. Thanks for doing this talk for us today.
Well, thank you for inviting me. It's quite the honor. I hear your voice so much, but I haven't seen you in ages. I hear your voice on Seizure Conference.
Right. Yeah, exactly. They like to keep our cameras off for that. Otherwise, it's just too many people on.
Yeah, exactly. Too much socialization would happen.
Exactly. Yeah, we're distracted. Cool. So I'll do a brief introduction and then it's all yours. And then at the end, we'll have some time for some questions. And I'll just field the questions through the chat function and then propose a few to you to answer, if that's okay.
Sure.
Awesome. Sounds good.
Just run through the slides, just make sure that they open.
Yeah, great. If you want to open your slide and you see that they're showing up, that'd be great.
Yeah, now let's see here. Should be okay. Can you let me know when you see my slides?
Yeah, I can see them clearly. Good.
Okay, terrific. And I can scroll through okay?
Yeah, that looks fine. It's your object.
Okay, perfect. All right.
Okay.
Stop share there. So I think we're in good shape.
Perfect. Okay, we'll just wait a couple of minutes and get everyone in.
I like the background music.
Good to see you, Jay. He's a guru at webinars and Zooms.
Hey, George. Good to see you on screen.
Good to see you. How are you?
I'm keeping very well, thank you. We have never met each other face to face.
I think, a long time ago, I remember meeting, but it's been a very, very long time. Very long time.
Oh, okay. But what I remember is, I think I profiled you as one of the rising stars in CLA.
Oh my goodness, that was far too kind. I remember that. That was in the newsletter, I think, a few years ago.
Yes.
You're far too kind. By the way, the reach of these rounds that you run is amazing. I got text messages from India, from the States, from Europe, saying that they heard about these rounds and they heard that I was speaking today. So a lot of folks have. This is a very popular program that you started. It's terrific.
Thank you.
Was this a COVID-inspired initiative?
Yes, that is one of the positive aspects of COVID.
Totally agree.
Yeah, Rajesh is like a Larry King of neurology.
Well, that I already knew.
It's trying to get us all to do this again. So a lot of spin-offs from this as well, which is also cool.
Oh wow!
Yeah.
Really.
As soon as this music stops, there is a 40-second video, Kevin.
Sure, just give me a thumbs up when you want me to start, Rajesh.
Yes, yeah.
George, just recognize that you're muted, so okay, welcome everyone to the Canadian Epilepsy's Teaching Network virtual rounds. My name is Kevin Jones, and I'm delighted to introduce our guest speaker today, Dr. George Ibrahim from the Hospital for Sick Children, who's going to be speaking to us about novel surgical approaches in epilepsy. Dr. Ibrahim is a pediatric neurosurgeon at the Hospital for Sick Children, and he's also an assistant professor in biomedical engineering in the Institute of Medical Sciences and the Department of Surgery at the University of Toronto. He's also a scientist in the Neuroscience and Mental Health Program and the SickKids Research Institute. His clinical and research interests include surgical treatment of medically intractable epilepsy, as well as spasticity and functional disorders in children. And he plays an active role in the comprehensive epilepsy, dorsal rhizotomy, and deep brain stimulation programs at SickKids. His research lab is dedicated to the study of neuronal networks in children with epilepsy and functional disorders using a combination of connectomic, computational neuroscience, and machine learning approaches. And his work has yielded insights into personal treatments for children, targeting specific network impairments and developing novel devices and treatment strategies. Dr. Ibrahim, I'm delighted to hear your talk this afternoon, and if you please share your slides and speak to us. Thank you.
Thank you so much. Really, really appreciate this invitation. I'm going to try to share my slides, and can you just confirm when you can see them, please?
Yeah, they look great. Thank you.
Okay, lovely. Thank you so much. So Rajesh, Kevin, thank you very much for inviting me to speak today. It really is an amazing group that we have here in Canada, and an amazing international community that we all belong to. I'm George Ibrahim, as you heard. I'm a neurosurgeon at SickKids in Toronto. I also have an active research lab in biomedical engineering at the University of Toronto, and I was tasked with the simple task of speaking about novel surgical approaches, which is, of course, an enormous subject that I hope I can do some justice in the next 45 minutes or so. A few disclosures that are relevant. I do have industry relations with LivaNova, which of course manufactures the VNS device, and they do provide me with research grant support as well as honoraria, which are relevant to this talk. Some of the learning objectives from today are to review the evolution of conceptual frameworks of epilepsy surgery, review technical advances, and discuss progress in neuroscience, neuroinformatics, engineering that really has allowed us to evolve our conduct of epilepsy surgery. As you heard, I'm a neurosurgeon at SickKids in Toronto, and certainly I would invite you all to please look me up if you're in Toronto. It would be wonderful to meet in person once this pandemic is over. And at SickKids in Toronto, I really have the pleasure to work with an incredible group of colleagues who really inspire and teach me on a day-to-day basis. These are the individuals in our comprehensive epilepsy program, which is led by Elizabeth Donner. And of course, my colleagues, Jim Rutka and Jim Drake, are the individuals that really contributed to the growth of the pediatric epilepsy surgery program at SickKids over many decades. Now, when we think of new approaches to epilepsy surgery, sometimes it's very easy to think that we haven't come very far in the last few decades. This is a photo that I found from a monogram from Wilder Penfield in 1937. And 80 years later, this was an epilepsy surgery case of mine in 2017. Looks very similar. The letters here denote various landmarks that we were mapping before we did a subdural grid implantation. And some might say that moving away from subdural grids towards stereo electroencephalography, SEEG, represents an advance in the last few years in North America. But these are monograms from the 1960s and 1970s from Telerak in Europe. And they look very similar to the photos that we use in recent cases of stereo EEG at SickKids. So it's very easy sometimes to think that we have a long way to go in epilepsy surgery, and the early years that really formed this discipline in the 1990s laid the foundation for work that's difficult to improve upon. In my view, though, these pioneers, the Penfields, the Teleraks of our specialty, laid the foundation for epilepsy surgery, and incrementally we've expanded our surgical approaches, our technologies and tools in ways that have allowed us to improve patient care over the last several decades. And I'll really focus on the last few years with a view towards the future, with a view towards what I feel are novel surgical approaches that are relevant for neurosurgeons, neurologists, neurophysiologists, families involved in epilepsy surgery. When you ask me where the most significant advances recently and into the near future are, I think that they fall within three major categories: technical advances, technological advances, and electronic and computational advances. And before delving into greater detail into each of those categories, I wanted to take a second to review the evolution of our understanding of various models of epilepsy that have allowed us to capitalize on these surgical advances to improve patient care over the last few years. As you know, many of the surgical treatments for epilepsy are really possible because we understand epilepsy as a network disorder. And the idea of epilepsy as a network disorder really arose from the work of Penfield and Jasper in the 1950s, where they suggested that an ictal onset zone, shown here in gray, initiates the seizures, which then propagate through a larger neural network, shown here as the little neurons, resulting in seizures. And identification and resection of this gray area would then be expected to result in seizure freedom. Telerak and Banco then expanded on this to suggest that there exists an epileptogenic zone. And this includes the area of ictal onset and also the brain regions that are involved in early seizure propagation. And resection of this epileptogenic zone is, as we understand, needed in order to achieve seizure freedom. Other authors, notably Susan Spencer, among others, proposed a larger network model of epilepsy, where instead of having focal generators, epileptogenicity is more distributed throughout a larger scale network. And this model proposes that disruption of connectivity among any one of these nodes would prevent or alter the manifestations of seizures. So from these different models and the evolution of these different models over time, the current surgical treatments of epilepsy can be inferred. First, one can resect the epileptogenic zone or disconnect it from symptomatic zones or areas of propagation. Or through surgical neuromodulation, for instance, through vagus nerve stimulation, deep brain stimulation, or responsive neurostimulation, we can modulate that circuitry and decrease the propensity for epileptogenicity. With that, I wanted to discuss novel surgical approaches that have emerged in the last few years that allow us to do this more effectively and more safely. And from a technical perspective, these include surgical techniques and novel intraoperative biomarkers. I will say that there was a period of time where epilepsy surgery enjoyed a very dramatic increase in variations on surgical technique. And take, for instance, the temporal lobectomy. Shortly after it was first described, different approaches emerged: the transtemporal approach, the transsylvian approach, the subtemporal parahippocampal approach, to try and do this procedure more safely through optimal corridors that minimize morbidity. And there's always opportunities to refine surgical techniques, but one might argue that we're starting to reach the limit of our ability to discover new operative corridors in the brain. That is, much of the technical surgical corridors that we have for epilepsy surgery have been explored. These are a few examples to suggest otherwise. These are recently described advances in surgical technique, and this is really the nuts and bolts of surgery. They include corridors or approaches such as multiple hippocampal transections for temporal lobe epilepsy involving the dominant hemisphere, the dominant hippocampus, the supracerebellar transtentorial approach for posteromedial temporal lesions in children with refractory epilepsy. And this was really popularized by one of my mentors, who's Sanjeev Bhatia, who passed away a few years ago, who worked for many years at Miami Children's Hospital. And of course, the endoscopic approaches that have gained a lot of fame and notoriety from work that largely came from India. And these include endoscopic callosotomies and hemispherotomies. And these are variations that allow for safer resections or disconnections through different tools or different corridors that we have at our disposal. One of the most elegant, in my view, is this approach. And I'll talk about it in just a little bit more detail as an example. This is a slide prepared by one of my friends and colleagues, Alex Whale at St. Justin Hospital in Montreal. And it just shows the anatomy of the medial temporal region that could be divided into the anterior, middle, and posterior segments. And accessing the posterior segment of the medial temporal region is really quite challenging. You can imagine a transcortical approach to the posterior medial temporal segment would necessarily put visual fibers at risk and would violate a lot of unnecessary cortex in order to reach that corridor, or to establish a corridor to reach that part of the brain. So the supracerebellar transtentorial approach utilizes the posterior fossa and a transtentorial approach to gain access to this very challenging area of the brain. And from the posterior fossa, the tentorium is incised to expose the basal temporal lobe directly. And this is the view that one gets from this. This is from a nice publication in 2012. And you see the tentorium is open. You see the blood vessels around the brainstem. This is the SCA. And you see the lesion that was resected, which is in the medial posterior temporal region, again, providing a very nice novel corridor to approach epilepsy foci in this area of the brain, which was previously accomplished with higher morbidity. In my view, though, the discovery of novel surgical corridors in this way is really reaching, to some extent, the limits of ways that we can approach them. Other technical advances that have opened up novel surgical approaches really largely relate to the discovery of novel intraoperative biomarkers that have guided our ability to perform epilepsy surgery. One of the main advances in epilepsy surgery approaches has been the development and expansion of neuronavigation systems, where we can link preoperative testing to intraoperative decision-making. And as many of you know, there's been enormous progress in many non-invasive mapping tools for seizure foci, including MRI scans, PET scans, SPECT scans, fMRI, MEG, and we could talk for hours about each one of these modalities and their contributions to epilepsy surgery. But suffice to say that all of these the results of all of these modalities are immediately and directly accessible to the surgeon in the operating room through navigation. And I'll give you a few examples of these. At our institution, we have a vast institutional experience in MEG. And as many of you know, MEG uses superconducting coils to record the neuromagnetic activity that results from electric activity in the brain. And that neuromagnetic activity can then be reconstructed into the source space where it originates in the brain based on an inverse solution that you impose on the MEG using various mathematical frameworks. And there's a few patterns that can be described from localizing the activity on the MEG in this way. The MEG can form clusters, they can form small clusters or scatters of dipoles. And Dr. Otsubo and Dr. Ochi at SickKids have really, in my view, pioneered this approach for many, many years at SickKids and have built quite an extensive experience of operating on children on the basis of MEG localizations registered to neuronavigation. And we've shown that these types of MEG-guided resections can result in very good outcomes and in some cases actually obviate the need for invasive monitoring and multi-stage surgery for these children. Of course, there's been integration of preoperative tools to map eloquent cortex into navigation systems as well. For instance, we can co-register fMRI activations or tractography to inform real-time surgical decision-making to perform these surgeries much more safely. And these are cases that are examples from my colleague, Dr. Rutka, of various lesions shown here in pink relative to the corticospinal tract or relative to the visual fibers that were mapped in this patient. And navigation has really allowed us to leverage advances in pre-surgical modalities to modify our surgical approach. There's also a rising trend in the development of intraoperative biomarkers that can guide resective surgery in real time. This is work done by Arya Fala, one of my good friends and colleagues at UCLA, in the development of brain tonometry to look at the elastic properties of normal and abnormal brain to try and facilitate more accurate intraoperative surgical decision-making about the extent of resection for epileptogenic foci. If you talk to your surgeons, or if you're surgeons yourself, you know that we often say that epileptic tissue feels different. The stiffness of that tissue is subjectively different when you're operating on it relative to normal brain tissue. To try to quantify that, we use the tonometer, which is very similar to tools that are used for measurement of intraocular pressure. And as you could see, you can reliably measure differences in the stiffness of different types of brain tissue, whether it be normal or, as you could see, type 2 focal cortical dysplasias, which are much stiffer than other pathologies that we examined in this publication. And these real-time tools can help us guide surgical approaches in real time in order to modify the surgical strategy and inform intraoperative surgical decision-making. By far, the largest and most important advance in epilepsy surgery, in my view, has been the development of novel electrophysiological biomarkers to guide the resective approach. And the biomarkers available to us to define epileptogenic foci were really limited to those that pertain to waveform shape and spectral properties. So waveform shape, I mean interictal discharges, the pattern of ictal events, DC shifts, spectral properties, focal slowing, paroxysmal fast activity, also DC shifts would fall into that category. And for many, many years, we were limited by the biomarkers that we had at our disposal to identify the epileptogenic foci. In the last several years, there's been an emergence of novel biomarkers that may be more predictive of pathological networks and may be more specific to the epileptogenic zone. And these include network-based measures, including connectivity, graph theory, neural fragility, and what I'd call advanced spectral properties, like high-frequency oscillations, phase amplitude coupling, otherwise known as the modulation index, which I'll talk about in a little bit more detail. Of course, many of you are likely to be familiar with high-frequency oscillations. This is a video transitioning of a patient transitioning into seizures, courtesy of Dr. Tom Akiyama. And as you could see, HFO maps on the top left here. This is just spectral power using a method that that Dr. Akiyama developed. Do reveal the areas of epileptogenic brain regions. Certainly my lab and other groups have tried to leverage advances in machine learning, in digital signal processing and computation to automate the detection of these high frequency oscillations so that you don't do this in a visual way as has historically been done. Newer research suggests that it's not just the high frequency oscillations that are critical, but also areas of the brain where high frequency oscillations are coupled to the phase of slower oscillations. And this is one of our earlier papers on this topic. There's been several in the past few years. But on the left here, I show a filtered signal with the right time series showing the time series of high frequency oscillations. And the bottom time series is a sawtooth pattern of the phase of slower oscillations in the brain. And as you could see on the right on these topographic maps, the brain regions where high frequency oscillations are locked to the phase of slower oscillations tend to co-localize with the core of the epileptogenic zone. And this is the idea of phase amplitude coupling or the modulation index, because the high frequency oscillations are modulated by the slower oscillations. And many groups are investigating these actively as biomarkers of epileptogenicity that are more specific to the epileptogenic cortex. And this is, I think, a promising biomarker that has recently emerged and I think will continue to play a role in our understanding of epileptic networks and our approaches to epilepsy surgery in the years to come. And finally, there's measures that don't just look at activity at one single electrode, but rather the pattern of interactions between different electrodes using network-based modeling. And this is an example of connectivity based on phase-phase interactions between all electrodes on a grid implanted in one of my patients as he transitions into seizures. The different boxes represent different frequency bands of analysis. And our group and others have shown that there is tremendous change in functional connectivity as the patient transitions into seizure that could potentially be leveraged to try and localize the seizure with more precision and maybe a more relevant biomarker of the epileptic networks than looking at individual electrodes separately. We showed, and many others have as well, that typically the epileptogenic area is functionally isolated at the start of seizures relative to other brain regions. So I think these technical advances, in my view, will continue to play a very important role in the coming years in improving outcomes for patients. And these technical advances will certainly continue to improve on surgical technique, but in large part, they'll build on biomarkers that are established and emerging to deliver better outcomes to patients undergoing epilepsy surgery. The next advance I wanted to focus on are technological tools that have changed our approach to epilepsy surgery. And there's many technologies that are now being applied to the conduct of epilepsy surgery. This is actually a very nice study by Pat McDonald and Judy Illes at UBC as part of an NIH-funded project evaluating how patients and clinicians approach decision-making when it comes to novel neurotechnologies for epilepsy surgery. And they describe various novel neurotechnologies that are neuromodulatory, that are ablative, that are diagnostic, primarily SEEG, if you consider SEEG novel. And they polled physicians at various meetings, the AES, the CPNSG, the ASPN, various clinicians at multiple meetings, and polled their familiarity with the different novel neurotechnologies that are emerging. And not surprisingly, clinicians were most familiar with vagus nerve stimulation and least familiar with focused ultrasound, which makes sense because that has to do with the trends and implementation of these technologies. And I certainly won't go into all of these technologies in this talk. We use the majority of them, not all of them, but it's very hard to discuss novel surgical approaches without talking a little bit about laser ablation. As many of you know, MR-guided laser interstitial thermal therapy has really enjoyed a very rapid expansion over the last several years for many indications, including mesial temporal lobe epilepsy, insular epilepsy, hypothalamic hamartomas, and many others. There are groups that are performing laser ablations for corpus callosotomies, for hemispherectomies, for disconnective procedures that are quite more extensive and pushing the limits of this technology. And really with any advance, we really have to pause and ask how to use available technologies and also when not to use them. Because when not to use something is actually equally important or even more important than asking when to use it. And I'll show an example. This is a patient of mine who underwent who has focal cortical dysplasia, who underwent laser ablation. As you see, the focal cortical dysplasia is in the bottom of the sulcus. This is a bottom of sulcus dysplasia, and it's in the right frontal lobe. So a few years ago, a very, very reasonable and safe approach would be an open surgical resection. This is a non-eloquent brain, and an open approach is tried and true and certainly very, very reasonable. Because of the depth of this lesion and because it's a lesser invasive option, we opted to perform laser ablation in this patient. And as you could see, the laser probe is inserted into the lesion. For bottom of sulcus dysplasias, I use 2 laser probes for the majority of the time on both sides of the sulcus, because the sulcus acts as a heat sink that doesn't allow heat to dissipate through. And as you can see, the blue line here shows the permanent ablation and very nicely overlaps with the lesion that our terrific neuroradiologist, Dr. Alyssa Wijaya, drew for us when we were planning this ablation. So certainly this technology has changed our approach to many epileptogenic lesions, and it serves a very, very important role in the care of patients with epilepsy for many indications. We're still learning how to use this technology, and this is a beautiful study of over 200 patients that have undergone laser interstitial thermal therapy for hippocampal sclerosis. And it clearly shows that how the ablation is done affects outcomes in the end. On the right here, you see a heat map of the positive and negative predictive values of ablations that resulted in seizure freedom. And this group beautifully demonstrated that ablations here that are representative by this green one that you see are more likely to result in seizure freedom, and ablations that are more red are less likely to result in seizure freedom. So the details of the surgical approach that we use are critical. And perhaps those details and how we plan and how we perform these surgeries are more important than the actual technology used. Because it's wonderful to apply laser interstitial thermal therapy. It's a less invasive tool that we have at our disposal. The recovery is less, the stay in hospital is less, but unless the patient outcomes are comparable, then that technology should not be used. And learning how to use this technology is really a critical part of applying it. The same is probably true for hypothalamic hamartoma. This is a study that we recently published using a high-resolution atlas of the hypothalamus, where we showed that there are probably tracts that connect the hypothalamic hamartoma to the hypothalamus that need to be selectively disrupted in order to achieve a higher probability of seizure freedom than other tracts that connect the hypothalamus to the hypothalamic hamartoma that are less important. And we're still very much learning about surgical targeting for hypothalamic hamartomas, particularly challenging ones that are giant hypothalamic hamartomas like this one here shown in this panel. As I mentioned, we're also learning when not to use this technology. And I'll show an example of maybe a time when I shouldn't have used this technology. This is a patient of mine, as you could see, with large MCA stroke, who's a candidate for hemispherectomy. This is, of course, the lateral periinsular hemispherotomy procedure. Temporal lobectomy is done. The ventricle is opened widely from a lateral approach, and I'll just emphasize one part of this surgery, the corpus callosotomy, which you're about to see in just a second. So in front of you here, this is anterior, this is posterior, there's the choroid plexus. I'm showing you here the foramen of Monro, and we're going transventricular and opening the corpus callosum and disconnecting it until we find the pericallosal arteries in the midline, in the interhemispheric fissure, which is what we found here. And we follow the pericallosal arteries anteriorly around the genu of the corpus callosum and then back towards the foramen of Monro. Careful, of course, not to disrupt any structures that we should protect. But the main point I wanted to raise was that this patient had a small residual tract that wasn't disconnected at the very posterior part of the genu of the corpus callosum. So one option, of course, is to go back in and to disconnect that tract. For this patient, we decided to try laser interstitial thermal therapy in much the same way as I mentioned. And let me show you the tract. This is the tract right here. It's about 3 millimeters in size. And we tried for a good hour to ablate this tract with heat, and it was nearly impossible. There was too much CSF around this tract. The tract was too small, and despite our best efforts, we were not able to achieve a good ablation because of the heat sinks around this tract. In this case, we took the child back for a microsurgical disconnection of that tract, which, to be honest with you, took less time than this laser ablation that we kept persevering for some time. So again, equally important is knowing when not to apply technologies to our patients. Of course, as you know, there are advances that have helped us become more accurate and consistent in the OR. These include robotic assistance for invasive monitoring, and these are great tools to improve patient safety and reduce surgeon error when planning intracranial invasive monitoring. I wanted to finish off with the last category, which is actually very near and dear to me because this is the category that I dedicate the majority of my research towards within biomedical engineering. And that's computational advances that have facilitated our ability to perform epilepsy surgery, for me primarily in children, but also in adults. In my view, the greatest advances in computation have really facilitated our ability to perform neuromodulation. And there's many tools that have emerged on the market of late to modulate these networks to reduce the burden of epilepsy in children and in adults. And as you know, neuromodulation has a huge role to play for children who aren't candidates for other interventions such as resective surgeries. The challenge is that children with epilepsy and adults as well are very heterogeneous with almost too many treatment options at this point. You know, devices like VNS, RNS, DBS, adaptive DBS is now coming on the market in the very near future. It's impossible to know which therapy is best for which child. And in fact, if we did a randomized controlled trial of all of these devices in children, we'd probably find that they all have the same efficacy. And it's not because they're interchangeable, it's because we don't know how to select the right child who would benefit from the right therapy. And this leads to a little bit of a danger of the 50% response in 50% of patients that we often quote to families. We often say this technology has a 50% chance of achieving 50% seizure reduction, which is, probably true if you look at the entire group, the whole cohort of patients. But if we're able to select patients and tease them out and deliver more intelligent neuromodulation to selected cohorts of patients, in my view, we'd be able to significantly improve our ability to reduce seizure burden. So if we take VNS as an example, we know that response rates are very variable, ranging from 25 to 65%. There's very few complications, but they do occur. And this means that there are some patients that undergo surgery and in the best case scenario don't have a response, in the worst case scenario don't have a response and have a complication. And there's also a lot of wasted resources because vagus nerve stimulators are very expensive. We know that clinical variables don't predict response to vagus nerve stimulation to an appreciable extent. This is some work from my lab showing an ROC curve, a receiver operator characteristics curve, which if you aren't familiar with it, the greater the area under this curve, the more likely a test is at predicting what it's meant to predict. And these are the clinical predictors of who will benefit and who won't benefit from vagus nerve stimulators. When we put them all together, the best predictive ability for vagus nerve stimulation that we find is about 50%. So really, looking at a patient and trying to see if they're going to benefit or not is almost no better than the flip of a coin at trying to determine which of these technologies should be implanted for that patient. So then if clinical variables aren't helpful, what data can we leverage to better predict response to surgical treatments? And we looked at various biomarkers for VNS specifically. And one of the main biomarkers, and really the only one that I'll talk about to any extent in the time that we have left, are network-based biomarkers that study the neural circuitry and predict response on the basis of brain network organization, which is a field of brain connectomics. And brain connectomics has really very much rapidly expanded in tandem with the expansion and advancement of epilepsy surgery. And this is one area where epilepsy surgery has really benefited from the gains in the neurosciences, in the engineering, and in the mathematic fields. And connectomics, if you're unfamiliar, involve decomposing communication between multiple brain regions into mathematical structures. For instance, these graphs, and on the top slide you see you can index connectivity in many ways, primarily functional or structural. And then these representations that we calculate, these mathematical models, can then be linked to some outcome of interest, including the prognosis to therapy, including neuromodulation like vagus nerve stimulation. And the underlying hypothesis to this entire field of connectomics and outcome prediction is that some brains are wired to respond better to different therapies like VNS, like RNS, like DBS differently, whereas other brains are predisposed to other therapies or maybe more amenable to other therapies to reduce the seizure burden. Another way to put it is some brains are better wired to respond to some therapies than others. We did a series of studies that seemed to support this notion. We did some studies with functional MRI scan that looked at thalamocortical connectivity and how that was different in responders and non-responders to VNS. And we found significant differences. And with the aid of machine learning models, we were able to make various classifiers to predict response to different therapies that we hope to test in larger studies, as I'll talk about in a second. We also use multimodal tools like DTI and tractography to validate these findings, and we found very consistent results. We typically found that responders to VNS have more normal-looking brains within specific circuits compared to non-responders to VNS. And those circuits are primarily thalamocortical association hemispheric and others. I won't go into the exact findings of this study in great detail, but we also explored this with other tools like MEG and found very consistent findings. Taken together, these lines of research have led us to describe the vagus afferent network, which was defined as the set of brain regions that are functionally connected and linked to the activity of vagus nerve stimulation and that relate to the responsiveness of therapy. And conceptualizing responsiveness to therapy like vagus nerve stimulation or potentially DBS or RNS as a connectomics issue allows us to then theoretically model intrinsic brain differences within a heterogeneous cohort of patients undergoing different therapies and try to tease out which patients are going to benefit from which therapy. And maybe the most important slide that summarizes this work is this one, where I showed you the clinical variables and the area under the curve here, which was no better than the flip of a coin, and these other connectomics-based tools that predict response to treatment with much, much greater accuracy. We do have, as I mentioned, a prospective study to validate these findings with multiple collaborators across North America, some of whom may be on the line today. If you are, hello, and thank you for your collaboration. You know, I would say that one of the greatest advances in epilepsy surgery is our ability to collaborate and our ability to pool together our resources to validate and discover novel biomarkers to improve outcomes for our patients. Of course, it's really important to define which patient benefits from which therapy because, as I mentioned, we have several tools at our disposal, both for children and for adults. And since 2018, we've had a dedicated, almost weekly, deep brain stimulation clinic at the Hospital for Sick Children. And we've treated many children. This was our first child who was treated in 2018. She was actually the first child in Canada to undergo DBS for epilepsy. Who has since had good responses, and many others have as well. But you know, I wanted to talk for a second about DBS in adults, and then talk about our approach in children, because as you know, there's many targets for DBS in epilepsy, including the centromedian nucleus, which is the one that I primarily use in children, but also the anterior nucleus, which is primarily used in adults. The hippocampus, there's also been descriptions of the cerebellum and subthalamic nuclei, but these are really fallen out of favor for many reasons. And of course, it's very timely to talk about this because the 10-year follow-up of the Santé trial was just published, showing a reduction of 70% in the most severe seizure type over a long-term follow-up. We also looked at the usage of DBS in children, and there's obviously not as much experience. We're building on this, and many others around the world are, and likely many of you are exploring this as an option for children as well. And in the published literature, most of the studies, similar to our experience, are in the centromedian nucleus, which probably reflects the greater proportion of extratemporal epilepsy in children, but we can certainly discuss that. But overall, this cohort had 85% demonstrated seizure reduction with deep brain stimulation. Again, choosing the right candidate for the different tools that we have to offer them is really critical. And in my view, that will form the basis for novel surgical approaches in the next 5 to 10 years. There's also a wealth of technology at our disposal to perform DBS, and that has seen many important advances. This is the Percept device in DBS, and I have no relations with Medtronic in showing this slide, but the Percept device, of course, allows us to record from the thalamus while we perform the deep brain stimulation, and these are recordings of absence seizures in a patient, and we've recently published how we use these recordings to optimize the programming of the DBS in the hopes of better selection of parameters and contacts to use to optimize the benefit for patients. And one of the leaders in this field is Alfonso Fasano, who I work with at SickKids, and Karolina Gorodetsky, who I work with at SickKids, who are really experts in programming, and I really learn very much from them and from working with them. So I'll conclude with I'll conclude it there to leave enough time for a discussion, but I hope that I've shown how novel surgical approaches are emerging on the basis of advances in techniques, in technologies, and electronic and computational tools that we have at our disposal. And though it seems like in 80 years between the time that Wilder Penfield was doing epilepsy surgery and the time that I'm doing epilepsy surgery, our craniotomy hasn't changed. Our understanding of the neural circuitry has evolved, and as has our surgical approach to epilepsy. And this evolution is really collaborative. It leverages advances in engineering, neuroscience, mathematics, robotics, many other disciplines, and large working groups that share data, that share experience, that work in multidisciplinary teams will really be the ones that propel us forward in pursuit of better outcomes for our patients that undergo epilepsy surgery. With that, I'd once again acknowledge the really enormous team at SickKids that I have the great pleasure to work with. And I'd be very pleased to take any questions or open this up for discussion surrounding advances in epilepsy surgery. Obviously, a very, very big topic, very important topic. And this is really just skimming the surface of where we've been and where we're going in the next few years. Thank you very much.
George, thank you so much for a fascinating talk. It tells us exactly where the state-of-the-art of epilepsy surgery evaluation is at. And thank you for just bringing everything together so neatly. While we're waiting a few minutes for some more questions to come in, I'm just going to start with one that's posted that you've probably heard a million times. Is how do you distinguish between physiological and pathological high-frequency oscillations? And does it matter?
Yeah. The answer is poorly. So we recently did a systematic review of all the high frequency oscillation detectors that are out there. They're really in three primary categories. Most of them either use the RMS of the signal, they use some sort of spectral decomposition of the signal, or they use machine learning to find high frequency oscillations. Those are the three main categories of HFO detectors. Very few of them, I would say none of them, really reliably get at the issue of whether they're pathological or physiological. There's some studies that are out there now that seem to suggest that when the HFOs are locked to slower oscillations, so when that modulation index that I showed is higher, it's likely to be more physiologic. But as I actually showed, and as we've published and shown, pathological HFOs are often locked to slow oscillations. Now, some folks are looking at the frequency that they're locked to. Some people think that the frequency of the slow wave to which HFOs are locked to could potentially determine whether they're physiologic or pathologic. But really, it is an open field, and you know, there's many experts in this area, potentially some that are on this call. I don't think that is a well answered question just yet.
Great, thank you. And just moving to the second section, which is regards to DBS and DNS and RNS. Is there any contraindication to using these devices in patients that have pacemakers, for example? Conflict, or can you use them?
So that's a great question. My challenge is I'm a pediatric neurosurgeon, so the question is probably geared towards an adult neurosurgeon. I've not had the experience of a child with a pacemaker that I needed to implant, so I don't think I can answer that. You know, so I've implanted many children with, I've implanted several children with DBS that have VNS in place. And certainly that is no contraindication. In fact, we use both simultaneously. We don't remove or turn off the VNS. We use both in tandem. And we've seen some synergistic effects of the two together. So that is a tandem technology that is certainly very safe to apply. Pacemakers, I think it's better, a question better posed to an adult neurosurgeon than a pediatric neurosurgeon.
Yes, certainly, I agree. It's not that often that we have pacemakers in our kids. Yeah, I have a question for you with regards to the use of Connectomics in our surgical workups. So for the patient, they come in, they have MRI, EEGs, and then PET and MEG. And if that is important to go ahead with surgery, they usually get invasive monitoring. So do you want to do Connectomic studies in all patients, or are they reserved for the select few where there's discordant data? Where do you see it fitting in?
So, you know, I think one of the challenges with any biomarker is knowing when to apply it and when not to apply it. And if you're going to test for it, there should be some way to use that data that you collect. We currently don't investigate connectomic markers outside of research studies. So all the VNS data that I presented, we don't use those to base clinical decision making until they're just better validated. You know, you can extend that and say all tests have positive predictive values, negative predictive values, sensitivities, and specificities. So, you know, for instance, a SPECT scan could show discordant data to a PET scan or to an MEG. And certainly we don't discount it. We just consider that discordance in the surgical decision making. So you can certainly apply them, acknowledging that if there's discordance, then you have to take it with a grain of salt because these aren't well-established biomarkers relative to others that have been around longer. But as of yet, in our practice, we're really only using them for investigational purposes. We're not using them in clinical practice just yet.
Okay, thanks. And then just build on that is the whole question of knowledge translation. So when you do surgical or epilepsy fellowship, we usually focus on the clinical aspects, and all of these new advanced techniques of Connectomics and analysis are left for later. Do you have any strategies or thoughts on how to bridge that gap between biomedical engineering and clinical medicine? Because for me, that's the challenge as a clinician.
Yeah. I you know, totally agree, and I totally concur with that. I think there's a responsibility on both ends. I think there's a responsibility on the clinician's end to become, of course, you know, engaged and to understand these tools. But I also think that the bigger responsibility is on the end of the scientists to translate these tools into clinically meaningful biomarkers that we can use as clinicians in our day-to-day practice. And I do think that that responsibility is disproportionately on them because we do have tools at our disposal as clinicians that are good and that we are comfortable with and that we rely on. So if something is going to be better than the standard of care, the onus is on the scientists to make it not only superior, but also to translate it in a way that's understandable and that's relevant to the clinician that's taking care of the patient. Now, there's a huge trend for surgeons and neurologists and you know, clinicians to take on both responsibilities. To you know, clinician scientists is an emerging trend, and I think that's one way to bridge the gap. But I do strongly feel that the responsibility disproportionately lies on the end of the scientists and the innovators to make it accessible to all of us.
Yeah, I agree. But I also think that as clinicians, we need to be open to new advances and not stuck in our ways. It can happen sometimes. So yeah, great point. I'm not seeing any extra questions. JP, do you have anything to add?
Yeah, so